Hello, I'm Courtney LaFave, and I'll be talking about hospice care and exploring barriers that prevent patients from utilizing hospice care for its full available duration. Hospice care can be utilized when a patient is expected to live 6 months, which is approximately 182 days or less. But as of 2002, the median length of stay is 18 days. The statistical information effectively highlights the gap between what's available and the actual hospice care usage. So what is hospice? Hospice is a holistic and interdisciplinary approach to end-of-life care. It includes medical care, pain management, and emotional and spiritual support. Hospice is an approach to end-of-life care. It is not a place. What makes it different from other areas of healthcare is that it treats the whole person, not just a disease or a condition. And the care is tailored to the patient's needs and wishes. Hospice gives the patient a voice and allows them to drive the plan of care that's aligned with their values. Care also extends to the circle of support around the patient, including their friends and family, or those who show up for them at end of life. Hospice receives full financial support through Medicare, and it can be utilized when a patient is expected to live 6 months or less. Typically, hospice care is provided in home, and a family member serves as the primary caretaker. The members of the interdisciplinary hospice team make regular visits to assess the patient and provide care or other services. Staff are on call 24/7 for questions, visits, and support. And I'm going to go back to this slide just to talk about the structure of the interdisciplinary team. And I really like this image because it represents the circle of support with the patient and the family at the center. And the team members include physicians, counselors, social workers, spiritual and bereavement counselors, hospice aides, therapists, nurses, and volunteers. Care can also be delivered in nursing homes, assisted living facilities, and residential facilities. There are also freestanding hospice facilities. What services are provided by the hospice team? Pain and other physical symptom management, emotional, psychosocial, and spiritual support for all aspects of dying. They also provide all medications and medical equipment. A really important piece is instructing the caregivers on how to care for the patient. They provide grief support and counseling to the patient, as well as the surviving family and friends for up to 13 months after death. Another unknown is arrangements can be made for short-term inpatient care for when the caregiver needs respite, or if it simply just becomes too much to manage at home. All of these services provide numerous benefits to patients and families, but with the short lengths of stay or waiting until the last few days of life, the focus then shifts to a primary objective of managing pain and symptoms, resulting in many missed opportunities for holistic care. Hospice has many confirmed benefits, including improved patient satisfaction, improved pain and symptom control, and the increased likelihood of goal concordant care, including at-home death. Patients experience a better quality of life, and family caregivers have reduced burden with hospice care. So with so many services available and the confirmed benefits, why is that median length of stay only 18 days? And understanding the barriers to accessing hospice is crucial to ensuring that patients can receive the full benefits of compassionate and holistic end-of-life care, aligned with their personal values. Through my research, I found that there were 4 common themes when looking at the barriers to accessing hospice care. And understanding the source of these barriers is an important first step in correcting them. Related to hospital and clinician barriers, there are a lot of opportunity-related environmental barriers, such as time constraints and workload for physicians, which results in less time spent with families and patients to have discussions about advanced care planning. There's problems with inadequate staffing, lack of training for clinicians in end of life. Referrals to hospice frequently do not happen in a timely manner, and some of that is due to the clinician's discomfort and uncertainty about declaring a definitive 6-month prognosis. There is some research about the financial structures for Medicare reimbursement. There is a per diem financial structure, which is a fixed amount per day, and that can lead some hospice agencies to consider other factors when deciding whether or not to take on a patient, such as medical complexity, cost, or other diagnosis factors. An interesting point is the per diem rate does not adjust for patient-specific factors. And the thin financial margins leave hospice organizations to weigh the risks and benefits of helping one costly patient versus the capacity to care for others. A really big barrier is misconceptions and myths about what hospice is, what it does, and what choosing hospice means. If patients and providers are not aware of the services, it doesn't even come up as an option to consider. There's a common misconception that choosing hospice means that you're giving up, or that somehow choosing hospice means that you are going to die sooner, and that's not true. But these beliefs lead to insufficient guidelines for the medical professionals and having policies in place, and this delays the referrals to hospice. These misconceptions also tie into psychosocial dynamics at both an interpersonal level and an intrapersonal level, and this occurs not just with patients, but with clinicians as well. As far as the psychosocial dynamics, like I said, it's both intrapersonal, which is what is going on inside someone's head, which can include fears that they have, their current level of knowledge and understanding of what's happening, their comfort levels with asking questions and having discussions, even their past experiences with death and dying. And then there's also the interpersonal psychosocial dynamics, which is what occurs between the patients, families, and their providers. There might be discomfort in initiating conversations for both the clinicians and families. There might be uncertainty about the treatment options or lack of knowledge. Another important piece is not understanding the prognosis or what life-saving measures mean. So having discussions about options is one step, but it should be taken a step further to make sure that patients understand the implications of those choices. And there's also a lot of conflicts that come up in decision-making at end of life, both within the healthcare personnel and within families. So with so many confirmed benefits including improved quality of life, effective pain and symptom control, reduced burden for caregivers, compassionate services for both the patient and the family. Understanding the barriers to hospice access is crucial to ensuring that patients receive the full benefits. These barriers are multifaceted, they're very complex and multi-layered. To increase the utilization rates for hospice care, further research is needed to provide insight for targeted interventions at both the micro and macro levels. It would be helpful to have research into the cost effectiveness of hospice and also the impact that hospice care has on patient outcomes. And hopefully that would demonstrate its value and support the need for increasing utilization rates. One of the things that makes hospice care so different than other areas of healthcare is the focus on the whole person, which means addressing the psychological, social, and spiritual aspects of suffering are at least as important as addressing the physical symptoms. And social workers are uniquely trained to understand and support these complex needs. Social workers have the ability to adjust like a camera lens from taking a wide angle or macro view, and also tightening our focus to a micro view, all while holding on to the understanding of the multi-layered factors influencing the present moment. So social workers are just right for doing the work needed to promote quality care at end of life. An interesting thing that came up in my research was that with so many patients receiving hospice care with little time left, that puts an extra burden on the social workers to have additional challenges to meet the patient's needs in such a short amount of time. So addressing these barriers is needed for social workers to fulfill their ethical responsibilities in supporting individuals at the end of life. Hospice utilization is influenced by the interrelationship among patient, family, and providers. Understanding the characteristics and needs of subgroups of terminally ill people is key to providing good care at life's end. And understanding how psychosocial dynamics influence the way choices are made at end of life helps social workers improve care for the dying. I hope the information provided here offered some clarity about what hospice is and the benefits of its approach to end-of-life care, and also that it's worth increasing the utilization rates. Every one of us and all the people we know and love will be at the end of life at some point, and I hope that we all have the opportunity to live and die in the ways we wish. I look forward to your comments and questions, and thank you for your time.